Hi everyone, welcome to the 2022 Year-End Hearing Symposium. My name is Yini. I'm part of the audiology team at University of Chicago. And today I want to thank you for joining me in this very interesting and very complicated case study. So I'm going to turn off my camera here so I don't become a distraction once we go into the presentation. So the learning objectives for this presentation. So hopefully after this case study, you'll be able to describe the vestibular presentation of patients with Chiari 1 malformation and also patients with 3PD. Hopefully you'll be able to discuss possible options for treatment and managing chronic dizziness. And we're going to go through how we apply current research evidence to support our clinical care and also the specific factors that apply to the case that drove our clinical decision-making. So I named the presentation a vestibular patient's journey, and here is his journey map. So we have patient NG, we will call him Nathan for this case. He is a 43-year-old Caucasian male. His symptoms started back in 2002, 2001, but he didn't really start investigating the cause of his symptoms until February of last year. So from February last year to September this year, he has been receiving care from multiple specialties for his dizziness. And we will talk about why after we go into his symptoms and medical history. So the major complaint of Nathan is lightheadedness. He onset it in 2002, and it has progressively gotten worse since 2017. Per his report, his episodes consist of a couple of different forms of dizziness that include lightheadedness, swaying, sometimes spinning, unsteadiness, a swimming sensation in his head. And the symptoms can be triggered by positional changes when he reaches up or when he bends over, with his eye movement, if he is watching traffic, pedestrians walking by his deep breath through his nose, and also physical activity. So sometimes he reported that when he walks up and down the stairs, when he walks in aisles, and if he is doing any physical exercise, the symptoms are triggered. So initially, the duration of the symptoms varied from 20 seconds all the way to a few hours. But since 2022, he has been reporting that the symptoms last about 1 to 2 minutes, but it does occur every day. And whenever he closes his eyes, he gets dizzy. So the symptoms have progressed to a point where he feels like it's impacting his quality of life. It's preventing him from participating in his daily activities. So besides the dizziness, he also had other complaints. So he reported chronic pressure and popping in his left ear. He has been having headaches for a long time. He described it as pressure in his forehead and also on the left side at the back of his head. Sometimes when he had the headaches, he will experience double vision. He also reported pressure at the back of his neck when he tries to look down or when he tries to lean forward. He has what he called a mental fogginess and also memory difficulties. And then on top of everything, he also experiences anxiety, depression, panic attacks, and also insomnia. Some pertinent medical history for Nathan. He was diagnosed with POTS last March, which can be contributing to his dizziness or lightheadedness when he stands up and when he walks or standing for a prolonged period of time. And it can also contribute to brain fog or the memory difficulties. He also has pituitary adenoma. So pituitary adenomas are benign tumors of the pituitary gland. This condition can lead to headaches and also vision problems. And to treat the benign tumors, he is using a medication called bromocriptine. This medication sometimes has side effects, including blurred or double vision, dizziness or lightheadedness, especially when the patient is having positional changes, it can make the patient feel that there is constant movement of themselves or of their surroundings. It might also cause headache and also lack or loss of strength in their muscles. So during the past year and a half, Nathan has been going through a couple of different treatment plans. So he was referred to vestibular rehabilitation therapy. He tried that for about two months, but he didn't really see any progress with that. He was also prescribed meclizine. He used it for a week and then discontinued because it didn't really help with his symptoms. But at the same time, he did report that marijuana helped to alleviate the symptoms for him. And also to treat his anxiety and depression, he was prescribed SSNRI for that side. So here are all the conditions mapped onto his journey map. So we can see that some conditions have a green check mark next to them. So that means he has received a diagnosis and is actively being treated for that condition. But also there are two other pieces of information that we have not been put back into this puzzle. So one of them is coming from neurology and the other one is coming from audiology. So Nathan has been receiving some conflicting information on his neurological finding. In March 2021, he went through a cervical spine radiograph, which showed a cerebellar ectopia. So this term is sometimes used to describe a mild form of Chiari malformation. So basically, the cerebellar tonsil, there was a slight protrusion through the foramen magnum. And usually patients with cerebellar ectopia, they don't exhibit any typical symptoms of Chiari malformation. But in February 2022, he did a brain MRI, and the diagnostician informed him that he actually has a small Chiari malformation. So the categorization of the diagnosis kind of changed, but they didn't see any compression of nearby structures. So the diagnostician didn't think that the small malformation is going to explain all the symptoms that he was having. And then moving on to September this year, he actually visited one of our neurosurgeons for a consult. And the surgeon told him that he didn't have any malformation on the imaging. The second piece of conflicting information comes from the VNG test results. So Nathan actually completed two different VNG testing. One of them was back in March 21. So at that time, he had a PE tube in his left ear. He had essentially normal hearing with a very slight sensorineural hearing loss in the right ear. The VNG back in March showed essentially central abnormalities. So the audiologist observed abnormal sarcode and smooth pursuit. They observed a right beating nystagmus in the spontaneous testing condition and also in all the positional testing condition. They also saw a downbeating nystagmus when they were doing positional testing. On the note, the audiologist said that they were not able to perform Dix-Hallpike due to the diagnosis of POTS. And also they only performed warm irrigation for caloric testing, which showed a weak response from both ears. But because they didn't complete the cool and the ice calorics, we can't really say that Nathan had bilateral end organ weakness. So to me, the peripheral results were kind of inconclusive. In August this year, Nathan came to University of Chicago, and we repeated the VNG again with some additional test batteries. So on his subjective measures, he scored pretty high on DHI, which is Dizziness Handicap Inventory. He scored 86 out of 100, which definitely indicates severe degree of handicap caused by the dizziness. On the dizziness symptom profile, his responses were significant for all the etiologies, except for Meniere's. So the questionnaire didn't really help us for the differential diagnosis. By the time he was here, his left PE tube had fallen out. So we got type A tympanogram in both ears. We also saw normal hearing with excellent word recognition in both ears. But his reflexes were essentially elevated and absent on both sides, which doesn't really line up with the normal hearing. So for the vestibular finding, which also kind of contradicts with the first test results, we saw normal central findings. No spontaneous, no gaze-evoked nystagmus were seen during the testing. All the ocular motility results were within normal limits. His positional and positional testing results are also negative. Although he did report subjective dizziness during Dix-Hallpike, we didn't see any positional nystagmus. However, if we take a closer look at the VHIT and VAMP results, there was some abnormality there. So this is just a screenshot for all the ocular motility. So basically central testing battery. So everything looked symmetrical and normal, which is great. Before we talk about the VHIT, I do want to note that the patient had some pre-head-turn eye movements. He was pretty anxious during the appointment, so the eye movements might have confounded with the tracing that we have right here. But basically, we can see that saccades were pretty much present in all of the conditions. And also the VOR gain was low in most of the test conditions except right side lateral. So it could be his pre-head-turn eye movements, it could be his anxiety, or it could be an actual vestibular dysfunction on the peripheral side. But it's just very hard for us to know at this time. We did ocular vamp. So it was present on both sides. Just to rule out superior canal dehiscence, we also performed the O-vamp at 4,000 Hertz. It was absent, which means that he was negative for SSCD. On the cervical vamp, however, it was absent in his right ear. Although we did get a response on the left side, it showed as prolonged latency with low amplitude. But again, he was negative for SSCD because we didn't see a response when we presented the stimuli at 75 dB. So after the BNG testing with us, Nathan went to see one of our otologists, and he was recommended to do the following. He was recommended to optimize his migraine management, maybe try different medications, continue to make lifestyle changes, maybe add some supplementation to his diet. He was also referred to an autonomic specialist to follow up on his POTS diagnoses because he really hadn't been following up with cardiology or any other specialty on that side. And then because we have this conflicting neurological diagnoses on whether he has or he does not have the Chiari malformation, he was referred to the neurosurgeon to clarify on that side. So I decided to do a little more research on Chiari malformation because the patient might have it, and because Nathan is actually exhibiting a lot of the symptoms that are on the list for this condition. So Chiari malformation comes from type 1 all the way to type 4. So each of the type just adds more severity of the malformation. So type 1 is the slightest, type 4 is the most severe. For type 1, you're probably going to see that in 25 to 77 people per 10,000 individuals. So basically, type 1 malformation just involves the cerebellar tonsils. You're going to see on the imaging that the cerebellar tonsil descend through the foramen magnum of more than 4 to 5 millimeter. So this condition is usually congenital, and it can also be acquired by certain procedures. For example, if a person has gone through a couple lumbar punctures, that is a risk factor for acquiring Chiari 1 malformation. we have about 15 to 20% of patients with CM1, they don't experience any symptoms. Usually for them, it's an incidental finding if they are investigating for something else, if they're getting the image for another condition. But over 75% of patients, they do report ocular or also neurological symptoms. So one of the most common symptoms they report is suborbital headache or neck pain. And it gets worse when they cough or when they strain. And other common symptoms include dizziness, loss of muscle strength in hands and arms. They might have double or blurred vision, and they might also be very sensitive to bright light. So Chiari 2 malformation, also known as CM2, involves a little more structure. So you're gonna see, in addition to the cerebellar tonsil, you're also gonna have the descent of the medulla, the fourth ventricle, and the cerebellum into the cervical spinal canal. You're also gonna see elongation of the pons and the fourth ventricle. I will show you what that looks like on the next slide. So the prevalence for CM2 is a little bit lower compared to CM1. You're probably gonna see 3 to 4 individuals per 10,000 people. This condition is usually diagnosed sometimes before the baby was born, because we have been doing a lot of prenatal screening and you are able to see that malformation on the screening. 20% of the children who are diagnosed with CM2 do have symptoms. And the most common one, I'm not gonna try to pronounce that word, but it's basically an open spinal cord defect developed at birth. Other common symptoms include hydrocephalus, neurogenic dysphagia, and also involuntary downward nystagmus. And as the babies grow up, they also start to show symptoms that are similar to CM1. So this is an image that I found in the paper by Piper et al. So we can see that for CM1, the only difference compared to the normal imaging is the downward displacement of cerebellar tonsils. Everything else looks pretty much the same. But for CM2, we're gonna see first hydrocephalus. And then we're gonna see multiple structures of the cerebellum, the brainstem, and the fourth ventricle. They're not only lower compared to normal, but also the structure has changed. It's longer than what you would have in a normal individual. And then on actual imaging, it kind of looks like this. So how do we diagnose CM1? I'm gonna start focusing on CM1 from now on, because this is possibly what Nathan has, or he might not have it. So to initially assess the situation, the medical provider will determine the nature of the headaches. When it happens, if it gets worse with certain positions, and they will also ask about possible acquired causes. So like I mentioned before, lumbar punctures, a risk factor for acquired CM1. And then in the appointment, they're gonna perform a comprehensive neurological examination to check out the sensory function, the motor function, the cranial nerve function of the patient. But to make the final diagnosis, to confirm it, you do need a brain and spine MRI. So I wondered if instead of an MRI, a CT would be adequate to make that diagnosis. And the answer is actually no, because the MRI provides more information than the CT when it analyzes the back of the brain and the spinal cord. So MRI is usually the preferred test. And we will see that later on in one of our case studies, the patient was actually showed normal results on the CT, but then diagnosed on the MRI. So common otologic symptoms of patients with CM1. In this pretty large scale chart review study, we have 364 patients. 81% of them reported headache. 65% of them had retroorbital pain, which is the same word for suboptimal pain. Over half of them reported dizziness and disequilibrium. 46% of them reported pressure in their ears, 36% had decreased hearing, and then 20% experienced true vertigo or spinning. So these actually are very similar to what Nathan has been experiencing. And that is one of the reasons why they suspected CM1 to begin with. So I couldn't really find a research paper that addresses the testing patterns in a uniform way. I guess all of the cases just vary on the individual basis. So I found 3 case reports. All of them, the patient was in their late 40s. So the first one, we have a female. So she was seeing objects moving, and it lasted for a couple hours for her. And then in the next few days, she experienced postural instability. She did not have any other neurological symptoms. She did not have any auditory complaints. During the ENG testing, the provider did see that she was having some left beating spontaneous nystagmus, and also in all the positional testing. During smooth pursuit, they observed square wave eye movement. She had normal hearing, and she also had negative Romberg testing results. The second case was a male. He reported rocking sensation for hours at the onset. He also had constant tinnitus in both ears and also progressive hearing loss. In the Romberg testing, he was deviating to the right side. He also had right side beating spontaneous nystagmus. But what's interesting to me, I briefly mentioned this before, he got a normal result on the CT, and he also got normal ABR results, which was not what I was expecting. But then he finally was diagnosed with MRI. And the third case is another female. Her complaint was unsteadiness and also neck pain at the back for years. The clinician observed down beating and right beating spontaneous nystagmus, and the eye movement was enhanced if she were to gaze laterally and also downward, and also when the vision was denied. And she actually completed a little more balance testing. They saw saccades for lateral planes on both sides, and also reduced gain for posterior planes on both sides. And then she had normal rotary chair results and also normal caloric results. So some common characteristics for these 3 patients is they all demonstrated lateral spontaneous nystagmus, and their main complaint was disequilibrium. None of them actually reported spinning vertigo. So for treatment of CM1, neurological surgery is definitely an option. So that usually refers to the decompression of the suboptimal region. So basically, because of the descent of the cerebellar tonsil, it creates a lot of crowding and depression of the nearby structure. And the surgery basically opens that up, lift it up, and give it more room for the nearby structure to function normally. So in this study, we have 10 patients. Most of them are in their mid-30s, late 40s. 60% of these patients reported recurrent vertigo and dizziness attacks. They also went through vestibular testing before the surgery, and 70% of them showed abnormal results, which are listed right here. So the author listed a lot of details for each patient in their paper. So on the left side, 6 out of 10, these patients reported dizziness attacks, vertigo. Many of them also had headache and double vision. And out of these 6 patients, 4 of them reported the complaints had gone away, And also the complaints have improved. The other option for treating CM1 is doing nothing. Sometimes the patients, they don't qualify for surgical intervention. Maybe their structural change is not as severe as some of the surgical candidates. But if we do nothing, what would happen? So in this study by Keeling et al., they examined 68 patients. We have 30% pediatric, 70% adult, and also 71% of all patients were female. The patients were followed up for around 5 years. Most of the patients reported migraines. They reported paresthesias. They reported cough headaches and ataxia. After being followed up for 5 years without doing anything specifically about their CM1, 74% of the patients actually reported improved symptoms or unchanged symptoms. And out of those symptoms, nausea had the highest frequency of improvement, followed by migraine headaches. So there is a pretty high likelihood that if we don't do anything for Nathan, that he will probably stay the same, or he probably is going to feel better down the road. So because we don't really have a definitive diagnosis for Nathan, and because he demonstrated a lot of behaviors for severe anxiety and depression, I was just thinking maybe persistent postural perceptual dizziness could be something that's also involved in this puzzle. So according to Stepp et al., these are the people who developed the diagnostic criteria for 3PD. The patient has to meet 5 out of 5 of the criteria to be able to receive a diagnosis. So the patient experienced 1 or more forms of dizziness, and the symptoms will be present on most days for 3 months or more. The dizziness will be exacerbated by upright posture, by movement, by exposure to moving or complex visual stimuli. And by that, I meant this. So any complex patterns, busy traffic, pedestrians walking, those would trigger the symptoms for them. 3PD can be precipitated by vestibular dysfunction, medical conditions, or just by psychological distress. But it will definitely cause significant distress or functional impairment for the patient. And also the patient probably have 3PD if their symptoms are not better accounted for by another disease or disorder. So 3PD is a functional disorder that's persistent, but it doesn't mean that there is nothing organically going on or nothing structurally going on with the patient. They can actually definitely coexist with each other. The prevalence of 3PD, 15 to 20% of patients who come to a specialty dizziness clinic are actually diagnosed with this condition. So that makes it first the most common diagnosis among young adults, and then the second most common for all adults. We definitely see a female dominance for 3PD. And most patients who are diagnosed are in their mid-40s. So the most common precipitating conditions for 3PD is peripheral or central vestibular disorder. So that accounts for about 25 to 30% of cases. If the patient has vestibular migraine, 15 to 20% will account for 3PD. Panic attacks or anxiety, they account 15% each. Concussive injuries, about 10 to 15%. Autonomic disorders, about 7%. And then all the other conditions that are capable of producing vertigo or any other balance symptoms commonly collectively account for about 3% of the 3PD cases. So for this slide, I just want you guys to look at number 3. So this is the maladaptation cycle of 3PD. So for a normal individual, something happens, they are able to return to their normal function. But for people who are high in anxiety, they have a lot more self-observation. So their perception of their somatosensory information, such as their body position or body movement, will be more amplified and distorted compared to people who have baseline anxiety. So this mismatch between their perception and their actual body position produces subjective dizziness, and also make those individuals on a higher alert. They want to monitor themselves more, but they ended up just reinforcing this vicious cycle. So for 3PD, I was able to find research papers that uniformly addresses the testing patterns. So because many of the patients with 3PD diagnoses have anxiety, they're going to have high scores on the hospital anxiety and depression scale, anxiety subscale, and also the dizziness handicap inventory. They're going to feel like the dizziness is impacting them more compared to other individuals. If 3PD is psychogenic, if it's only precipitated by psychological factors, you're probably going to see normal objective results. But if other disorders are involved, you're probably going to see abnormal results. A very common clinical observation for anxiety is square wave eye movements. So because people who have high anxiety, they rely on their visual information a lot, you're going to see a poorer performance from them if you put them through the sensory organization testing. So in conditions 2, 3, and 4, they're probably going to perform worse compared to a normal individual or even individual with vestibular disorder. So in those conditions, so the first one, vision denied, they do not have access to visual information at all. In 3 and 4, there is a mismatch between their visual information and the somatosensory information. And that mismatch is usually the trigger for their dizziness symptoms. And for bedside testing, if you do it vision denied, you're going to see some exaggerated movement and some exaggerated strategies of those patients to try to maintain their postural stability. So usually you can see that in Romberg and also the modified clinical test of sensory interaction and balance. If you do a head shake testing, depending on the precipitating factor, depending on if there are other disorders involved, you might see normal or abnormal results. So finally, we're going to talk about how to manage persistent or chronic dizziness. So in Nathan's case, we are already managing a lot of his medical conditions that might be contributing to the dizziness. We're waiting on a diagnosis from the neurology. And also we have undecisive results on the audiology, otology side. So what can we recommend? What can we do? So we're all pretty familiar with cognitive behavioral therapy. We use that for tinnitus patients, and I think it's in the same mechanism, because CBT helps patients to live with or help them to adapt to chronic medical conditions. So I think it definitely can be applied to Nathan's case or any person who is suffering from chronic dizziness. So we know that the goal of CBT is to break that negative cycle. So this cycle is coming from appraisal of the situation, then to the emotions triggered by the situation, and finally the behavior conditioned by the emotion. CPT or the therapist will try to encourage patients to see the symptoms as non-threatening and encourage them to refocus on their productive daily activities. And also CBT will try to encourage a certain degree of acceptance because the dizziness is gonna be there. The patients will need to learn how to coexist with their symptoms. Some common techniques that CBT utilizes is greater exposure to threat stimuli, relaxation techniques. They try to help their patients to reduce avoidance and safety behaviors, and also they utilize mindfulness and acceptance techniques. All of those techniques will help the patient to restructure their threat appraisals and try to help them regain the control of their symptoms and also the control of their normal function. So I found two studies that look at the effectiveness of CBT. The first one is a retrospective review. The patients were treated with CBT for up to 6 sessions. And most of the patients completed a comprehensive vestibular evaluation. So out of the 150 patients that they were reviewing, almost half of them had anxiety and PTSD. 25% of them had vestibular migraine attacks, 10% BPPV, 4% Meniere's, 4% head injury, and 4% of neuritis or other vestibular disorders. And this pie chart shows their vestibular testing results. So half of the patients actually had normal VNG results. 18% of them had unilateral weakness, 4% BPPV, 20% abnormal C or O VAB results, and then 7% just non-specific positional nystagmus. So the way that the authors measure the effectiveness of CBT is by having the patients fill out DSI, DHI, list their avoidance and safety behaviors, and also the DAS-21, which is the depression, anxiety, stress scale, pre and post treatment. So what they found is 42% of the patients showed a reliable change on their DSI, 45% on DHI, 40% in reduction of avoidance and safety behavior, and then 27% in anxiety. The second study that I have is actually a randomized control trial. So there is an experiment group and also a control group. So the experiment group consisted of 41 individuals. And after receiving CBT treatment, 75% of the participants actually achieved clinically significant change on their dizziness handicap inventory. They also showed significant reductions in their symptoms based on the DSI, and they demonstrated significant changes in their behavior. They're more willing to engage in regular activities. So these participants are different from the previous study because in the previous retrospective review, the participant actually received vestibular rehabilitation together with CPT. But in the second study, they did not receive VR. So this study was able to prove that you can achieve better outcomes with CPT even without the inclusion of vestibular rehabilitation, which is really promising. So we're approaching the end of my presentation. So a couple take-home messages. For patients who experience persistent dizziness and anxiety, we probably need to consider the possibility of 3PD. We can start discussing cognitive behavioral therapy as a possible intervention option with patients suffering from chronic dizziness. And third, of course, we need to continue to appreciate the interdisciplinary efforts in dizziness management. We definitely need the collaboration from all the specialties that are involved in order to give patient the best care. I thank you guys for your attention. If you have any questions, comments, if you want me to send you the slides, you can definitely email me with the address right here. Here are my references. And I thank you again for your attention.